Hello, everyone. My name is Ekhtiari, and I'm delighted that we have this opportunity to get together here and start the Addiction Neuromodulation Forum right at, 9:02. So I'm happy that we are on time. And I hope that will be an enjoyable and fruitful experience discussing about potentials for addiction neuromodulation. So we have a series of speakers here. So we hope to be able to be on time by the end of the meeting. Before getting started, I was really interested to kind of thank few colleagues and supporters. Of course, Marom has done a huge job putting us together. So many thanks to Marom, and also Colleen, who was the main figure behind the idea, supporting, putting things together. So thank you very much, Colleen, for co-chairing me this kind of event together. And I also like to kind of thank Mark Thomas from Medical Discovery Team, University of Minnesota, who has been supporting us, the network, and putting things together. And also Arash, my new postdoc here, he was putting the slides together. I was just sending messages every hour, 4 a.m. today in the morning. So thank you very much, Arash, for kind of making those things happen. Hopefully things are not going to be that complex in the next months. So this is about his third week with us. So as you can imagine, so it's just not the best kind of starting experience for a postdoc. But thank you very much, Arash, for supporting us in this process. We are going to have an addiction neuroscience meeting in Minnesota, October 28th. Those who are interested, you are definitely welcome to join us. But let's get started. So here, just giving you an overview about what we already have in addiction neuromodulation, and we are going to discuss about what will be the future and how we can promote the field. So let's start with a kind of an idea about what was the first neuromodulation study that was published in the field. And it was a TS or a TMS study. And what was the year? Anybody has an idea? Who was the first one who did addiction neuromodulation study? Felipe Fregni, okay. Any other guesses? Logio, okay. Who else? Shimbali. Olszeman. Okay. So these are the first ones. So the first one was nicotine 2003. It was a TMS nicotine study 2003. And then TMS 2007, first TDCS was Bogio, as you mentioned. And then other studies with cannabis, with opioids. And over the time, we have the first study. So the field is pretty new. So people has recently started to work on different ideas in terms of doing neuromodulation, non-invasive neuromodulation for addiction. And there are some kind of new advancements in the field with, for example, receiving the first FDA clearance for smoking 2021, first individualized TMS study in 2023, first kind of HDTDCS study. All those new advances are still happening in the field. So the field is pretty new and things are moving forward. And that is the excitement that we have in terms of how we might be able to put people together and make things in a better quality in the future. How many TST and TMS studies we have so far? How many published trials that we have in the field so far? So we have 227 till end of June with TMS and TS studies. So the field is growing. So we already have over 200 published trials in the field, and the field is kind of moving forward. So we are going to discuss about 7 challenges, and we have Marom here. Marom, we are doing fine here. So we still do not have but I'm shouting. So we are moving forward. And thank you very much, Mark. Yeah, thank you very much, Marom, for putting us together. So 7 challenges. First of all, discussing about the best targeting biomarker. What would be the best way, what would be the best area to target? And there are lots of discussions. Ghazale, one of my postdocs, she's mainly focused in terms of what would be the right area to target. And there are multiple targets. People are targeting things beyond the LPFC. Some new studies with parietal cortex stimulation, kind of frontopolar area, the area that Colin started to be focused on, and the connection with subcortical. So there are lots of new ideas in terms of what will be the right area to target. And if you look into the published literature in whatever we have in terms of the publications, and we will get there in terms of the further details, Ghazali will present some of the ideas that we have from meta-analysis. But it seems that what we have here, as you can see here, I mean, the highest number of studies are for left dorsolateral prefrontal cortex with excitation of that. It seems that there is an effect there. Frontopolar, there are some other ideas. With H coils, there are some ideas. For TES, we have F4, F3, F3, F4, probably highest number of publications. And I mean, we can further discuss about that. And we are going to have a specific two panels on Friday discussing about those ideas, or even the model that we are working on with Ghazali in terms of the basically dual target models, both DLPFC, frontopolar cortex, and even kind of the idea of how we might be able to have multiple targets in a trial, both stimulating dorsolateral prefrontal cortex, suppressing frontopolar cortex. Can they go together? And it's interesting that there is a recent publication by Min Zhao from Shanghai Mental Health Institute that they did a sort of pilot trial trying to do both a stimulation on DLPFC with ITBS, suppression of ventromedial prefrontal cortex with CTBS, and then an arm with combination of both. So putting both of them together. And they showed that basically the combination arm is the green arm. And as you can see here, the level of craving reduction is lower in the combination arm. And also those who have been sort of responders, they have the highest one in the combination. So the ideas of even if we might be able to combine them together. So beyond best target biomarker, the idea of outcome measure selection. What will be the best outcome measure? So that is going to be something that we will discuss today in terms of what will be the best ideas in terms of selecting different outcome measures, and there are going to be lots of discussions about that. And in the trials that we are doing, there are varieties of different outcome measures that people tried. Of course, craving was the most frequent one, then consumption relapse, and then some other types of outcome measures. And Arash will talk a little bit further about the things that we have in this area, and also the outcome, the significant outcomes from these different outcome measures that we have in the field. But as you can imagine, even for things like craving, we have varieties of different craving measures that people use in different trials. Or when we talk about consumption or relapse, there are varieties of different measures, but there are self-reported measures, there are objective measures, and how they basically play with these measures. There are going to be discussions today to see what's going to be the best way to do that. But the idea of how we can have better neuromodulation interventions, how we can enhance the quality of the interventions. Can we combine them with medications? There are, for example, in areas like ECT, we know that probably lithium and SNRIs would be a good combination with ECT. Do we have any ideas in terms of what could be the good combination or bad combination for increasing the efficacy of interventions? Is there any chance that we can promote priming and exposure and putting people in a state that would be more responsive to a stimulation? Colin will give us ideas about that. And then dose in terms of what would be the right dose. And even kind of for TMS trials in depression, I mean, they have been in place from 2007 with their first FDA approval, as you can imagine. There are larger databases. For example, they showed that for TMS in depression, you need to have a minimum of 30 sessions to get to that level of quality of intervention. So what would be the minimum number of sessions that we need to, in addiction, to have a clinically meaningful or the best types of outcome measure that we can get from a stimulation? So that is going to be another discussion that we can further discuss. The idea of individualization, how we might be able to individualize interventions. And when we talk about individualization, the idea of targeting, optimizing the target in an individual level, optimizing the context cues, kind of the medications, other things in stimulation, and also the dose, how we can individualize dosing, and how we might be able to individualize timing of its stimulation. So there are ideas around that, and we are writing a paper on that with Ghazali and Colin. So we are already discussing about the dimensions about individualization. But I mean, SAND trial in depression was really is still very much inspiring the idea of individualized interventions, starting with depression, and the idea of, okay, I mean, they have been able to do individualized stimulation in the most negative connectivity area with subgenual cingulate cortex, and they showed that there is a really good significant outcome out of that. But the trial has multiple other factors beyond individualization, including acceleration and those adjustment, other things. And also they compared it with sham. So there is no comparison between individualized versus non-individualized. And there is a recent publication from University of Nottingham, and they basically try to compare RTMS, one-size-fits-all RTMS, and ITBS individualized based on the connectivity to right anterior insular cortex. The outcome was negative, basically. They have not been able to show any significant difference between individualized stimulation and one-size-fits-all stimulation. So do we need to do individualization? So that is going to be another area for further discussion. And then the idea of how we might be able to develop biotypes in terms of who's going to be responder, who's not going to be responder. And you have heard about, I'm sure most of you, you kind of read the Drysdale paper 2016 from Connor Liston team. They basically tried to use some behavioral self-reports in combination with resting ST fMRI to develop some biomarkers or biotypes for depression. And basically they showed that these biotypes would respond differently to dorsomedial frontal stimulation with TMS. And do we have anything in addiction? I mean, how we might be able to define different biotypes who are responding to frontopolar stimulation or dorsolateral prefrontal stimulation? Can we have different biotypes? If you want to have different biotypes, what would be the behavioral dimensions? For example, here is about anxiety versus anhedonia. I mean, in addiction, should we think about relief during cures versus reward during cures? What would be the dimension that we need to consider from the behavioral side? Maybe NIDA phenotyping battery, and then the imaging side, how those things could go together and provide us with biotypes. How we might be able to have, kind of increase access, digitized trials, how we can give people home-based devices with low cost that they can use. That is another area. Safety is an important issue in terms of, I mean, do we have any concerns? I mean, is there any risk for seizure? If we have somebody who is actively using stimulants, is there any chance that we can just reduce the risk? Are we going to do TMS in somebody who is already, I mean, all those things that, I mean, are we cautious enough, or are we, I mean, kind of innovative or cowboy enough? I mean, the combination is always an issue in terms of how we can do the right thing for our patients. And also, at the end, team science, how we might be able to work together, how we might be able to do things together. So one of the things that we have been doing in the process of developing the field, we basically, in 2017, we started a network of labs that are doing TES-TMS trials, and Colleen was, I mean, one of the main supporter of the idea. So we put together a paper in 2017, and it was published in 2019. It received like over 260 citations so far. So we started from that point, and now we have a network of some like 54 different labs around the world that are collaborating with this network. And the meeting that we are here right now for is basically one of the outcomes of that sort of collaborative partnership. We have a YouTube channel. We are going to record the talks today. We are going to put that in that YouTube channel. Hopefully people around the world would be able to use the resources. Even we try to put together a guideline for those who have been doing TMS research during the pandemic, supporting the community. So whatever we have been able to do to put things together. So right now we are running what we call a living systematic review and meta-analysis to collect data in a sort of online way. Whenever we have a new publication, we just add it to the new database and run the meta-analysis again to have some kind of new outcomes, and Ghazale and some other lab members are working on that. So the idea of how we might be able to do things together, and Ghazale will give you further ideas in terms of how we might be able to collect data together and do things together in the future.